Hi, this is Austin Nakatsuka at the University of Texas Medical Branch presenting a case called Managing an Anterior Capsule Tear with the Bowl-Out Technique. This is a case of a 36-year-old prison inmate with a dense anterior capsule following trauma. We start the case by staining the capsule blue with trypan. The rhexis is initially started in an area not occupied by the plaque. An attempt is made to tear through the plaque with the Utrada's forceps, but this proves to be unsuccessful. An incision is made inferiorly at 6 o'clock to allow better access. Retina scissors are then used to dissect through the plaque. The rhexis is then continued until reaching the supero-nasal corner of the plaque. At this point, high tension on the capsule extending from the corner of the plaque is noted, and further attempts to tear through the plaque are abandoned. Retina scissors are then used to again cut through the plaque to relieve tension on the capsule. The rhexis is then continued and the inferonasal corner of the plaque was able to be circumvented. The remainder of the rhexis was then able to be completed. The remaining corner of the plaque was removed, but a small discontinuous anterior capsule tear remained. In order to avoid putting increased stress on the anterior capsule tear caused by rotating the nucleus, the bowl-out technique was employed. In this technique, the lens is thinned out with a phaco instrument on sculpt setting. The goal of this technique is to make a structural bowl of the lens with a very thin posterior. Viscoelastic on a Bink horse cannula is then used to dissect the lens from the posterior capsular bag. This effectually prolapses the lens into the anterior chamber. The lens is then removed carefully with the phaco instrument. A thin layer of cortical material was deposited on the capsular bag, so the IA instrument was used on the polish setting to remove this. The lens was then placed in the capsular bag with the haptics placed at the 3 and 9 o'clock positions away from the area of the anterior capsule tear. Viscoelastic is then gently removed away from the area of the capsule tear as well. The wounds were hydrated, the lens was stable in the bag, and the next day the patient looked great with a best corrected visual acuity of 20/25.